Yeah, good morning all. So now after a beautiful talk from Dr. Ross Blank, I would be talking about ARDS in traumatic brain injury in pregnancy. And these two cohort of patients seems to be very different from what we typically see in our day-to-day practice. And I'll tell you why this is. Uh, well, we all know now familiar with the ARDS, correct? It's a heterogeneous disease. You have bilateral lung infiltrates. If you get a chest X-ray like this or a CT scan like this, likely this is ARDS because of any number of causes. It could be secondary to pneumonia. It could be secondary to contusions, aspiration. It could be extra pulmonary causes. There can be multiple causes for ARDS, but we all land up in. If the patients are in ARDS, they will all end up in very similar picture. Correct. Well, there has been some iteration of definitions, as you must have listened since morning. The most importantly, we don't need patients now on ventilator to define a patient with ARDS. You can actually define a patient with ARDS even if a patient is hypoxemic, and we don't require PA to FiO2 ratios now. You can define ARDS, classify patients with ARDS just by looking at SpO2 and FiO2. This is a bigger change because this is very much applicable in our settings, which are resource limited, which many places may not have the ABGs to identify the right PO2. Correct? In those cases, we can use SpO2 or FiO2 to classify a patient whether the patient is in ARDS or not. Second thing is with newer therapies, the addition of high flow nasal oxygen and the NIV and CPAP has crept into the definition. You can still classify patients into an ARDS even if they are receiving a non-invasive ventilation or they are put on high flow nasal oxygen. They can be classified as an ARDS patients. You don't require patients to be on mechanical ventilator to classify a patient with ARDS. And then there are traditional ways looking at that you should be able to exclude reversible causes like cardiogenic edema or a volume overload. Many times I get patients who are just fluid overloaded, they land up in ICU with hypoxemia. Those patients are not ARDS patients. You just need to take out the fluid, they would get better. Right. What about the mortality? Now, if you look at over the decades, the mortality of ARDS has gone down substantially. It started, used to be somewhere between 70%. It is up to 40%, and even if you look at the Australian data, they have reached up to 20%. There has been significant decline in the mortality. Well, one can argue that we have become much better in ventilating these patients, handling ARDS. On the other hand, our criteria of classifying ARDS has become much more liberal. So both the things are happening, and we are classifying many more patients who may not have typical ARDS, but they are classified as ARDS. And that can actually show us the reduction in mortality. We have been talking about all these strategies like conservative fluid management, driving pressures, mechanical power reductions, pulmonary vasodilators, neuromuscular paralysis, VV ECMOs, glucocorticoids, individualized PEEP titrations, low tidal volumes, prone positionings. These are the gamut of interventions which we can offer to our patients, and we think that many of the things patient would improve subsequently. So these are all gamuts which are available to us. We can offer this to the patient and see whichever works in the individual patient. Well, then if the patient does not respond to this, then we have rescue therapies like neuromuscular blocking pair agents, prone positioning, recruitment maneuvers, which can still be offered to the patients having refractory hypoxemia. Well, when we are ventilating these patients, we have only two objectives. One is to treat hypoxia, and more importantly, to prevent further injury to the lungs, what we call as ventilator-induced lung injury. These are the only two goals with which we ventilate our patients on ARDS. We want to prevent further hypoxia, we want to treat hypoxia, and we want to prevent further villi. Well, that's easy because till now we become much familiar what we can do to our patients on ARDS, right? It wasn't so difficult that I'm ready to get a new patient on ARDS. Everybody would be familiar what to do. There are published protocols, how much FiO2, how much PEEP has to be given. Or you can go to the compliance curves and look at individualized PEEP titration. You can add steroids, you can prone the patients, you can institute early neuromuscular paralysis. These all can be done much more protocolized, right? But what about a specific group of patients? Traumatic brain injury or patients with acute brain injuries, right? What about these patients? Do you think your conventional way of treating ARDS would work in these patients? Anyone? Do you think they are very similar?
No.
What are the challenges here? PEEP cannot be given. Okay, one is, we will see what can we do. One is PEEP cannot be given. What else? One is permissive hypercapnia. Okay, what else?
Fluid-based.
Fluids. Okay. Secondary. Oxygenation for brain. Well, if you look at all the trials, big trials which Dr. Ross has talked about, Dr. Raghu has talked about, they are one similarity, one commonality. What is that commonality? All patients with traumatic brain injury or patients with raised ICP, they were excluded from the trials. They were not part of the trial. They were not part of the trial. Okay, they were actually excluded. And same goes even with the pregnant patients. They were excluded from the trials. Okay. So whatever we have read about, it's applicable to the patients who are actually included in the trials. However, traumatic brain injuries, patients with raised intracranial pressures, they were completely intracranial bleed, they were excluded. They were not even studied. So then what we are left with? So what is the concern? ARDS is independently associated with increased mortality and poor neurological outcomes in all prototypes. If the patient have a traumatic brain injury, if the patient along with that have an ARDS, it's going to have a worse outcomes. Cognitive deficits and mood disorders are frequent long-term sequelae of ARDS that can complicate traumatic brain injury. And the targets, specifically the ventilatory and hemodynamic targets, which you consider for ARDS, can actually harm the acutely injured brain. That's the problem. Your targets which you are looking for in ARDS, those can harm the injured brain. So there is always a conflict between lung and the brain. What to focus on? And these are conflicts. On the one side, you have neurologic treatments, and on the other side, you have pulmonary treatments. Neurologic treatments, you want to give increased oxygen, increased mean arterial pressures. You can have transient hyperventilation, sedation, paralysis, hyperosmolar. You can offer them cherectomies, right? Pulmonary targets are increased PEEP, low volume ventilation, proning, sedation, paralysis, inhaled dilators, and ECMOs. Carbon dioxide, you are basically giving low volume ventilation. This can all increase the carbon dioxide. Intracranial pressures, PEEP and proning can increase intracranial pressures, right? So there are absolute conflicting interventions and conflicting targets for both the organs. And there is a lot of physiologic interaction, what we call as cross-talk between brain and the lung. One side you have injured brain that causes more injury to the lung, leading to ARDS. ARDS, on the other hand, releases inflammatory markers which causes more injury to the brain. So it's sort of a vicious cycle which keeps on running if the patient has both the problems. What we call as secondary insults. The first hit is the brain, which releases a lot of inflammation. It goes into the lung, and you are ventilating with higher tidal volumes, inadequate PEEPs, infections. This can all cause secondary insults. So it's a vicious cycle which keeps running in these patients. And there have been experiments which have actually looked at how specifically the ARDS and intracranial hemorrhage patients actually interact. If you look at this, what is this? Extravascular lung water. And extravascular lung water is a marker of injured lung. In these experiments, they looked at the control patients with only intracranial hemorrhage, with only ARDS, and with the both combinations. And the patients or the patients, if they had ARDS and AICH, they had a higher extravascular lung water. That means there is a higher injury to the lung. Similarly, there is a lung to the brain. They specifically looked at S100B and neuron-specific knowledge, which are a marker for injured brain. The patients which had ARDS and intracranial hemorrhage, they had a higher these markers. So ARDS and lungs, they can cause injury to each other. What about PEEP? Now PEEP is very, very interesting to look at. PEEP does not have a linear relationship. If you increase PEEP, ICP, it's not going to have an increase in ICP. That depend upon the presence of third factor that is called as compliance. If the lung is highly compliant, then the effect of PEEP would be translate into the cerebral perfusion pressure, right? But if the lung compliance is poor, the transmission of PEEP is not linear to the brain, So this is what they looked at. They looked at that there was not a linear transformation of the PEEP leading to intracranial pressures. What about recruitment maneuvers? As for the PEEP, the effect of recruitment maneuvers depend upon the type of recruitment maneuver. As Dr. Ross has clearly shown, there are multiple types of recruitment maneuvers. You can use for pressure control, you can go for staircase recruitment maneuvers. However, the effect on ICP is not straightforward. It again depends upon the compliance of a lung. If the compliance is bad, the effect may not translate into the raised ICP. What about supine and prone position? Can you prone the patients with a traumatic brain injury? Right. Well, again, they had done experiments and they looked at the change in the ICP. Well, there is some change in the ICP. The ICP does increase, but not to a very higher limit. Again, depending upon the compliance of the lung. So these patients can also be prone depending if you are monitoring the ICP. What about ECMO? ECMO can be instituted in a patient with traumatic brain injury with hemorrhage in the brain, provided they are heparin free, provided they are not using anticoagulation. Well, these are the expert recommendations for what target should you go for if the patient has both ARDS and intracranial hemorrhage. You can look at individualization of PaCO2 and PO2 targets. Don't go for conventional targets, you have to individualize. Okay? You have to institute cerebral monitoring at much earlier compared to other patients. Well, the goal is to keep PO2 of more than 110 mm of mercury. What about high PEEP? Ideally, you need to maintain PEEP below 12 cm of water, but consider PEEP titration based on ICP monitoring. You can keep increasing PEEP till the time the ICP remains within reasonable limits. It does not increase further. So you can actually titrate PEEP. It's not that you can't give PEEP. There's nothing like yes or no. You have to individualize PEEP. Recruitment maneuvers you can avoid using with PEEP of more than 20. So below 20 you can still give recruitment maneuvers, but that lesser pressures compared to the only ARDS patients. Prone positioning, well, you can consider pre-medications prior to proning. Reverse Trendelenburg, you can do head down position of 30 to 45 degrees. Midline head positions, avoid ICP, monitor dislodgements, specifically when you are proning these patients. And alternatively, you can consider supine chest compression with weights. This paper I had published almost 10 years back with supine chest compression with weights. This was a case report which I had published almost 2014, 2013 in patients where we could not prone because of certain regions we could not prone. So what we did is we applied weights over the chest to improve the VQ mismatch. And that was considered is still considered as an alternative strategy. ECMO, you can avoid jugular cannulations in a patient with traumatic brain injury. You can consider alternate sites. Well, fluid conservatory status is careful. You have to assess fluid status with volume resuscitation. Sedation and neuromuscular blockade, you can consider alternatives. If you are worried about assessments, neurological assessments, you can use short acting agents. And steroids, there is no particular role of steroids, but yes, you can do based on patient-to-patient variation, patient-to-patient risk-benefit ratio. So one important thing is monitoring. How do you monitor ICPs? Well, we have conventional direct ICP patient monitors, but we can also do using non-invasive monitors. We can go for optic nerve sheath diameters. We can do transcranial Dopplers to monitor these patients. These are the basically non-invasive way of looking at ICPs. Now, experts have given strategies where both these strategies can converge. That is the tier 1, tier 2, tier 3 therapies for ICP targets, and then you have tier 1, tier 2, tier 3 therapies for ARDS. And you can actually converge them based on which part of the curve the patient lies. So you can converge which position, which intervention to be used based on ICP targets. This is, I find it much more interesting because if the patient has a high ICP, I can select which intervention can be provided to that patient out of all the intervention of ARDS. Now this was about traumatic brain injury. The other specific consideration is about pregnancy. Now pregnancy patient, as traumatic brain injuries were not included in the trials, so the pregnant patients were also not included in the trials. Whatever we have is based on physiology. Pregnancy does produce a lot of physiological changes. What are the physiological changes? Can someone enumerate in pregnancy? Low tidal volume. In fact, tidal volume increases. Mate ventilation is increased. Low bicarbonate reserve. Well, there have changes like physiological changes. The PaCO2 is decreased because of high respiratory rate. There is an elevation of diaphragm. The lung, actually, the diaphragm is pushed up. The heart rate, blood volume is increased. Blood pressure reduced. Cardiac output is increased. If you look at the tidal volume, which is increased, but FRC, which is a capacity, residual capacity, that is diminished. There is a mild alkalosis as well because of respiratory failure. So these are all the physiological changes of pregnancy. Well, but there are the conditions which can predispose these patients for ARDS development. One is the preeclampsia, eclampsia, they can all complicate into ARDS. If you put these patients on mechanical ventilation, well, you need to worry about what are the physiology of these patients. These are not as physiological as what we are. They would need to have increased mate ventilation of more than 40%. Your target PaCO2 would be between 28 to 32. Permissive hypercapnia, which is the standard teaching for ARDS, is contraindicated here. You can't keep this patient's CO2 in a permissive hypercapnia because maternal hypercapnia will lead to fetal acidosis. Fetal acidosis. Similar to the brain where you are monitoring brain, here you have to monitor fetal circulation. So you need to institute monitoring of fetal circulation, right? You have to use lung protective mechanical approach, but then there are other things you need to worry about. Passage of drugs into the fetal circulation, which drugs can be used. There is a high risk of failed intubation. There is elevated diaphragm with low FRC. Okay, you have to use high PEEP. Fetal monitoring is an essential part. If the patient with a pregnancy has an ARDS, you need to monitor the fetal circulation, fetal monitoring. Conservative fluid management, high risk of pulmonary edema, if avoiding uteroplacental insufficiency, both can occur. So these patients are quite tricky to manage. Proning them can be a problem, but yes, you can prone. There have been case reports, case series where the pregnant patients with full gravida, they have been proned for oxygenation because hypoxia will lead to fetal hypoxia. So the principle is use low tidal ventilation as per ARDS NET guideline. The total lung capacity is very similar, but tidal volume calculation by idle body weight remains valid, right? In these patients, the idle body weight would be slightly higher compared to what we calculate. Maintain plateau pressures of less than 30 because that despite decrease in chest wall compliance. Adjust for pregnancy. Normal pregnancy tidal volume higher than the ARSNET target. Increase respiratory rate first. If hypercapnia persists, cautiously increase tidal volume without exceeding plateau pressures. You can give increased tidal volume in these patients. Prone positioning lack evidence and not routinely used, but yes, there have been case reports where people have been prone with pregnancies.
Sir, can you explain the first point again? You said to increase the respiratory rate first.
Yeah.
But in normal pregnancy, tidal volume increases.
Yeah, normal pregnancy tidal volume is increased, but the compliance is reduced, right? If you look at, because of gravid uterus, push diaphragm, if the ARDS is developed in these patients, first you have to increase the respiratory rate, and then you have to increase the tidal volume, because increasing tidal volume would increase the plateau pressures. Hypercapnia, you
calculate the tidal volume based on
minute ventilation. So these patients would have a higher minute ventilation compared to other ARDS typical ARDS patients.
Yes, and that is because
That is because there is a physiological need for increased minute ventilation. Correct. Because here you are dealing with two lives. One is mother, other one is child. Delivery consideration, delivery may reduce oxygen requirements, but benefit in respiratory failure are variable. Mechanical ventilation after delivery still often requires prolonged periods. So, treating patients with pregnancy, full-term pregnancy, these are physiological challenges. Your permissive hypercapnia is not acceptable in these patients. These patients would eventually require the higher respiratory rate. The data about managing ARDS in these patients is quite scant. Quite scant means they are just limited to case series and case reports, right? They are not randomized controlled trials which support similar interventions in this group of cohort of patients, right? So these two things I wanted to discuss about in conclusion. ARDS with head injury and ARDS with pregnancy poses distinct challenges. They are not typical patients. There are actually challenges because you have to be there and do the balancing act. Evidence to guide management in such patient is often limited. Close monitoring is required in both the cases. In brain, you monitor the brain functions, ICP, whereas in pregnancy, you need to monitor fetal circulation. The goals of ARDS is to take into account physiological demands of pregnancy and fetal circulation. Research is still required because we need to have some data which suggests that following strategy is beneficial and other strategies may not be beneficial. We don't have that as if now. So this is what we do routinely when we face such patients. As an intensivist, we try to balance both the harms and benefit of these patients. Right? Any question you want to ask?
Thank you, Kapil. Very nice presentation. I just want to add from a neurosurgical perspective, because what I feel is most of these ARDS patients after head injury, severe head injury, they are actually sympathetic, discharge or release of sympathetic, which we misdiagnose as ARDS. So they are happening within 72 hours. Very fast the patient deteriorates, white out lungs, because all the permeability goes for a 6. And the anesthetists treat them completely wrongly. I'm on a continuous battle with my intensivist for the last 3 years.
This is what happens.
And they are treating like a normal ARDS, all these things. And I tell them, do not start phentolamine. I don't know why we don't have it available, because that is a drug of choice. So we are ending up giving clonidine and propranolol at very high doses. Intensivists keep giving them NORAD. I said, we do not want NORAD, we want dobutamine, because it's the cardiac contractility also goes down, because patient is hemodynamically unstable in these cases. And we are losing a patient in, let's say, one patient in every 3 months. So because of this, it's very difficult to treat these kind of changes.
This is the same thing which happens
in severe head injury patients. And they have those severe sympathetic discharge. And because it's a diagnosis of exclusion, there is no test to say it's a sympathetic discharge. Because it's a case of severe head injury, we know this is happening.
Yes.
So there's a disconnect between the neurosurgery team and the intensivist team.
And that is the much more challenging part than giving an intervention.
So for every single thing you're fighting, we had a patient who had similar picture, multiple cardiac arrests, somehow survived. Finally, we got, because high dose propanol, everything I started, but the patient finally had an amputation because of the high dose NORAD which was given in one leg. So patient walked on one leg home, let's put it this way. So because of these problems, I think there needs to be a new entity definition.
Yes.
That we don't call it ARDS in head injured patient, we call it something else.
Yeah. So this is I find this chart as one of the most fascinating because it actually takes into account both uh, the brain problems as well as lung problem. You can actually balance out which ICP tier along with which therapy is beneficial to be placed on. You don't straight away go to high norepinephrine and nothing straight away. So you need to have tier therapies which matches the patient need. And there's a one way of instituting both, saving brain as well as you want to save lungs, right? So this is one of the safe way. It's not the only way. People, there may be lot of disagreements, but this is the best. In my practice, I follow this one of the chart, right? This gave me some very clear picture which therapy I can institute if the lung is getting bad. I don't need to straight away go to patients on a high vasopressors or a high prone and everything. I can tear it out, right? So again, it varies. There is a lot of variability, as Dr. Deepak has clearly said. Variability occurs because there is not enough data. There is not enough data. There is no, and these patients are challenging patients. Dr. Deepak, I completely understand we want to say brain and the lungs are getting bad because of the brain. Once the lung is getting bad, the bad lung will worsen up the brain as well. So it's a vicious cycle, right? Sometimes you have to stop that cycle somewhere.
So one couple have taken care of a few pregnant patients today, I guess. And one of the things you have to decide is when to consider an early C-section.
Yeah.
And that becomes a tricky issue if they are in the early part of the third trimester.
Yeah.
Likely we will end up with an early C-section.
Yeah.
It does, and that seems to at least take one part out of the equation and then concentrate on the other part.
Yes. But again, just taking out fetus from the mother will not immediately reverse the lung condition which has already been damaged, right? So obviously it's one of the parts because you want to take out one individual out of the game, and then there is a mother which can be managed with the conventional ARDS interventions. Any other question you want to ask?
We will continue the questions. We are
Thank you.
running a little late, so we'll start.